practices.
Thank you, George. I took the liberty to change the case I'm going to present. So this is a case of yesterday. I thought it would be very interesting to show today. We did it with Michael, and we lost our sleep for the night before the procedure, thinking a lot what to do with this case. So that's why I wanted to share it with you. So, it's about a doctor who is 76-year-old male, normal shape, as you can see. And he underwent a thoracoscopic mitral valve repair, one of the cases we've seen earlier, with 3 cordae and a physio 2 ring number 32. That was just 10 months ago, so towards the end of last year. Initially, he had an excellent immediate result, but then the last few months he started getting tired again, exertional shortness of breath, and he came back with a relapse. Corneal angiography from before surgery was okay, ex-smoker, hypertensive, normal ECG, a high-pitched pansystolic murmur indicative of relapsing MR, normal blood pressure, and this is his drug regimen. So this is a transthoracic echo. When he came, initially it became obvious that there was a problem, and you can appreciate that there is some degree of mitral regurgitation, and you can also appreciate the long leaflets. And here you can see some degree of aortic regurgitation also, but it's probably mild to moderate, not more than this. Some also mild to moderate tricuspid regurgitation without pulmonary hypertension. I'm going to transesophageal to explore the mode of failure. It is obvious that some cordae are broken, have failed, and that part of the posterior leaflet that was DMR with posterior leaflet prolapse is prolapsing again. So this is what we see here. This is the pathology in the middle and a little medially. The other thing you can see is the fibroelastic dysplasia appearance of the leaflet, so very long anterior leaflet, as you can see, extremely long. And again, the color of the pathology, a large PISA, that is not going as you would expect anteriorly, but it's going mostly laterally, and you'll see in a moment why. And also you can see here the color of the aortic regurgitation in diastole running just below the anterior leaflet of the mitral valve. So take a look at that color, because we'll need to make an assessment later. So here we cut the valve in the middle. We don't see the prolapse of the posterior leaflet. We see the very long anterior leaflet. And we can see there is some distance of the anterior leaflet from the septum on the other side. And some other views. So this is a 3D appearance. So you can see the pathology is here, but you see the flail, it is going a little laterally. That's why the color has a direction lateral, anterior and lateral direction, not the pure anterior you would expect from a posterior prolapse. So some more 3D imaging from Michalis to see better the etiology and the anatomy. You can see the color on live 3D with color. And here we see all the measurements. So it was torrential MR with an ERO of 1.23 and a mean gradient of 1. That is good, I guess. And then we also got CT angio exam information for him. And what we found is what we would expect to see. So we have a rather appropriate and large angle between the aortic and the mitral curtain. the area of the ring is 537, and we did all the simulation about going for a valve in ring there, and we found that we had sufficient neo-LVOT in case we decided to go for that treatment solution, depending on how deeply in the atrium a Sapien 29 valve would go. We had a neo-LVOT of 2.8, 2.9, so more than sufficient. And then we looked at the anatomy on these videos to see what is happening with the anterior and the posterior leaflet in diastole. As we said, and as we noticed from the transthoracic, the anterior leaflet was really long. So despite that the neo-LVOT was more than enough, there was a worry about the behavior of that anterior leaflet once you go and you implant a valve. And so according to the application we all use, that ring is amenable to valve in ring with a 29 millimeter Sapien valve, and some more imaging to see that anterior leaflet. And you can imagine if you put a valve there where that leaflet would go, it could create some sum blown by the systolic blood flow, or if it overhangs over the valve we're going to implant there, it may actually cause some dysfunction of that valve. Both have been described. So we had a lot of discussion about what to do to this patient. We thought about just to prevent this issue of having some after implanting a valve to perform a tip-to-base lampoon. As you can see here from other cases, but we know that this is not always, as described, a perfect procedure. Just from this study, you can see that 10% of the patients, 2 of the 20, underwent surgical procedure, operation, for a complication or for something not completely corrected. So in summary, we have an elderly patient with early DMR relapse from failed CODI, severe MR, symptomatic patients, and we have these options. Send him back to surgery, redo surgery, with or without stenotomy, whatever. Do a valve in ring TMVR, do again a valve in ring TMVR, but with tip to base or rescue in case we implant the valve and we see the problem later, lampoon, or go to empty through the physio ring. So what would your approach to this be?
Nice case. I'm glad you changed it. Nice case. I'm glad you changed.
Okay, thanks.
I would go for a repeat TEER because there's enough length, acknowledging the difficulty in anatomy, but you have enough length of the posterior leaflet, and you've got a great imager too, so you're going to go spot on, head on, and fix it.
That's the issue. You have a great imager.
However, if you couldn't do that, there is an option of doing valve in ring with either lampoon or even preferably with Batman, and my next case is going to show that. So you can implant the valve inside the anterior leaflet, and you can do that transfemorally. Paolo Denti presented 3 cases, right, and it's something which is not that difficult to do, actually. But TEER is the first option, in my opinion.
I'm glad we had exactly the same way of thinking. So after a lot of discussion, initially the problem was that the patient didn't want to have a repair. He was fed up with the repair. He said, I want a valve. I want to eliminate my MR, so I don't want a clip. Just put me a valve. So there was a lot of discussion between us, what is correct, what is not, and a lot of persuasion to him to accept that we would make the decision for him. So this was exactly our strategy.
And he's a doctor, right?
Yes.
So even better.
Yeah. So this was exactly our decision to go and try TEER. My fear or my anxiety for TEER was that the leaflets were very long, especially the anterior. So we would just clip the tip of the anterior leaflet, and I was worrying about a lot of motion and of mobility of SLDA. So that was my worry. And then if I had residual MR or if I had a SLDA after that, I would have no other option just to go to surgery. But anyway, after a lot of discussion, although he wanted this, we put him to sleep and we went to this. So this is just from yesterday. So this is the tending on the septum. This is the height. And this is a safe set wire through. This is the SLO, 8 friends through. You can see the safe set and the SLO through. And this is how a Pascal catheter is going through the guide. This is the appearance of the guide after the removal of the dilator. And then we're coming again down to our pathology, reassessment, and then MPR. MPR, and as you can see, Michael putting the calipers in the correct position, you can see the red line. It shows exactly where we want to go and what kind of leaflets we're going to see there in the grasping view, and also what kind of rotation we need to have for the device. So this is the Pascal ACE. This is directed towards the valve, and then we open it and we do the clasp check just to make sure which is anterior, which is posterior before going down. And then we position it, the cloaking of the device before we go down, and we check again after we go down. And then because the physio ring brings the leaflets closer, the anterior posterior, usually there's no difficulty. And as you can see, once you go down, the leaflets are sitting on the pelvis immediately. And then we see that we're not medial exactly to the area we want to go. So Michael told me, no, this is not a good position. Don't try there. But I said, I'm there. I want to try to see what I'm doing. So I did it. So this is open, and you'll see now the clasps are down, and we are closing the device here. So the device is closed. And as expected, and Michael predicted, there was color from medially because the pathology was there. So, okay. So we're opening the device, and as you can see now, the device is moved medially. The leaflets are always sitting, no problem with the leaflet sitting. And you can see how the device goes higher and the clasps falling down. Immediately by looking at this, I don't like the anterior leaflet, how much is in, so we do optimization of the anterior leaflet immediately. So the clasp is up, device is going higher, torque anteriorly, and then you'll see towards the end of the sequence, the clasp is falling, and immediately now you see all the bouncing of the anterior clasp that tells you that you have the entire leaflet inside. So the device closes, and now we have a better result, but there is still some color from somewhere. So not a lot, but there is some medial and from the posterior, as you can see here. So what we do then is we check the clocking, and we decide that we need to be more counterclocked. So we open the device, and we just rotate like less than 5 degrees counterclock, because there is the pathology. And then we go up again. You see the anterior leaflet, how is probably curling in the device, but it's so long that it would almost certain that it would curl there because it was extremely long. So we do immediately this optimization again on the anterior leaflet. So you see how the clasp is going up and then down again. And then you see this bouncing that when we see it, we know we have the maximum of the leaflet inside. You see how it bounces. So we close it. And we have good result, very little color on the medial this time, but you see both leaflets are well pulled in. We have a mean gradient of 3, which is good, no problem. And as usually we're restless. When we're using Pascal, there's no limitations to how many times you open, you close the device. You can have like 100 attempts on the leaflets because it's automatic. So we open to make an assessment, and we wonder, should we optimize the posterior? Although at the initial clasping, we're sure that it was inside, so say, okay, let's optimize the posterior. So this is the optimization of the posterior. You see how the clasp is now up, and wait for the right timing. When the leaflet is going down, then we drop the clasp. So we did, we optimized both. We closed the device. And this time, well, we were happy earlier, but this time we are happy that we're not going to have an SLDA, because SLDA in this patient will be a disaster. So we close the device and we do this. This is something we like to do in most cases. We like to measure the leaflet length in the area we put the device from the baseline. So you see the posterior leaflet length was 1.3, and then we measure how much of this leaflet is outside of the device when it's closed, so 3 millimeters. So this means that we have 1 centimeter of the posterior leaflet in the device, which is the maximum you can have. This is the paddle of the ACE, 10 millimeter. You cannot get more than this. So we're very happy, and now we are releasing the device, so this is a release. And this is our final result, which is excellent. And any color you see is the color from the aortic regurgitation. If you notice, that's why I pointed out to you earlier, some color you see there in the anterior leaflet is the diastolic phase from the aortic regurgitation. So this is how we entered the case, with just 1 ACE there in the middle. And this is the final gradient, mean gradient of 3, and this is the final 3D imaging with 0 color coming back. You see it's quite rotated because we respect the anatomy of the leaflets in this area. And this is a little of PFO anatomy there. This is the sound. We have the very little flow from left to right after removing the device. Thank you for the attention.
Well, impressive result with such a difficult scenario and this very thoughtful approach. You did the right. Any comment, Blas?
Can I be a little bit provocative? Ottavio Alfieri used to say that the Alfieri stitch doesn't work by itself unless you put a complete ring. So the surgery was a bridge to TEER, right?
This is another way of seeing that.
And also just a clinical comment. In this scenario of residual MR post-surgery, usually the LV is not that dilated as you expect conventionally, because there is a functional component. If you apply exercise on this mitral valve, you will have impressive results. So at rest, the LV is not that dilated. But if you perform exercise, then you see the dynamic result of the phenomenon. So congratulations once more, Kostas.
Thank you.
So we shall proceed to the next one. Blas Ninios with his great